Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, welcome to Melanoma Matters. My name's James Larkin.
And I'm Sapna Patel.
Today we're going to be talking about the RELATIVITY-047 nivolumab, relatlimab trial. So Sapna, maybe you could run us through the background and the trial design.
Yeah, so this is a study for frontline metastatic melanoma using dual checkpoint inhibition. So it's nivolumab in combination with relatlimab. Nivolumab is an anti-PD-1 antibody. Relatlimab is anti-LAG3, lymphocyte activation gene 3, which is just another checkpoint that negatively regulates T cells. We see them often co-expressed with PD-1 on TIL, also sometimes on natural killer cells and other cell types. So RELATIVITY-047 was a randomized phase 3. It was a phase 2/3, and when it met its primary endpoint for phase 2, it rolled into a phase 3, randomizing patients 1-to-1 to either nivolumab as a single agent or nivolumab in combination with relatlimab as a fixed dose combination, with the primary endpoint of progression-free survival alone, so a single primary endpoint, and this was assessed by central review.
And what's the bottom line there in terms of the PFS, and how much follow-up do we have?
Yeah, so the original report had a little over a year of follow-up. I want to say maybe 14 months or so. And it did show that the combination was superior statistically to single agent nivolumab in terms of PFS. And so on that basis, it was approved in the US by the FDA as frontline treatment. So that was our second dual checkpoint inhibitor approval in the frontline setting in the US. And then EMA, the European Medical Agency, approved it for PD-L1 expressing melanoma less than 1%. And, you know, I don't presume to know the inner workings of EMA and what they were thinking, but, you know, that's a subset analysis of this study. I don't really know what to make of them limiting that approval to just low expression.
Yeah, well, I mean, I good to talk about that in a minute, I think, actually. And just for the record, while I'm talking, our approval and reimbursement actually is not PD-L1 restricted here in the UK, so it's kind of akin to the FDA. So I was really pleased to see that when it came along, but we'll talk about the FDA in a minute. So what about the difference in response rates between Nivo Mono and Nivo Rela? And I guess where I'm driving here is, how do you think that stacks up with the response rates for nivolumab and ipilimumab in CheckMate 67?
Yeah, I mean, we're not supposed to do that, but of course we do it all the time. So the response rate to the Nivo Rela, let me just check my notes here. I had it somewhere.
It's about 10% on the upside, so isn't it pretty much
44% for the combination, I think. So in the Nivo monotherapy arm, it was 33% objective response rate. In the combination, it was in the 40s, about 44% in that first report. Numerically, though, that's different than what you'll see in CheckMate 067. In CheckMate 067, the Nivo monotherapy arm had that 44%, you know, roughly objective response rate, and the combination was in the 50s. Now, there's some differences there. The CheckMate 067 trial was investigator assessed. RELATIVITY-047 was blinded independent central review, what some people call BICR. And it's pretty well known that blinded reviews, central reviews, tend to lower response rates and lower some trial metrics. So maybe that's part of it. There would be some thought, is that study population equitable? You know, was it the same frontline population enrolled in CheckMate 067 and Rela 047? But really, if you really pull it apart, the 067 study had a sicker population. It had a higher percentage of higher LDH and declining performance status compared to Rela 047 combination arm. So other than there just being a numerical difference, I'm not sure how else to say it. What do you take away from that?
Yeah, well, I mean, I take it as a sort of, the upside on the response rate is probably around 10% for Rela, maybe a
Mhm.
little bit more, but probably more than that, I think, for Ipi-Nivo. And I suppose the other thing that I'm thinking here is that we know that Ipi single agent has activity, has an approval,
Yeah.
has a response rate, and it's you see lots of different response rates quoted for Ipi mono, but I kind of work from 20% for whatever reason. But obviously, a lot will depend on the patient, and the patients who are symptomatic, high LDH, very low response rate to Ipi mono, maybe zero actually for really high LDH.
Yeah.
But nevertheless, clear single agent activity, and that's what we had sort of 10, 15 years ago, I suppose, activity in brain mets as well. So then, the question is, well, what's the single agent activity for Rela, do you think, if any? Do we really even know that?
We do. We know there's no single agent activity to relatlimab, but in combination, it seems to be boosting. But maybe I can challenge you on something you said. The Rela addition to Nivo monotherapy seems to get you about 10% in objective response rate if you read the trial numbers. If you read the 067 trial numbers, doesn't the addition of Ipi give you about 10% more than Nivo monotherapy just in the trial numbers?
Yeah, we might be at risk of splitting hairs, but I think if you sort of like maybe go back to the original publication, it's probably about 15% or
Okay.
slightly more than that. So yeah, but I mean, this is probably a cross trial comparison we definitely shouldn't engage in. So the PDL1 thing and the EMA, if you look at, I mean, PFS primary endpoint. And if you look at a plot, PDL1 expression and LAG3 expression for that matter, in all the different subgroups in Relativity-047, maybe one of the reasons to labour this response rate thing is that you can see for PDL1 that that you can pick out a group where the PFS is quite similar, but actually, if you use response rate, actually there's still a differentiation there. So
Mm-hmm.
I know that the PFS was the primary endpoint of the study, but I'm nervous, honestly, about looking at those subgroups retrospectively and using them for decisions related to approvals. And maybe my extended sort of rant on this subject would be that actually when Ipi-Nivo went to the EMA, which was quite a few years ago, we had exactly the same discussion about PDL1 expression and whether for Ipi-Nivo there should be a restriction on the label, in as much as it would only have been approved for PDL1 negative.
Yes.
And I was in the room actually when this was discussed at the EMA, and I argued vociferously actually that this wasn't the role of the regulator to make a view on this, and that actually this was a discussion for clinicians and patients to work out whether or not PDL1 expression in this case was a marker that you were going to use to try and make treatment decisions. And it's exactly the same argument.
Was that
Actually,
your was that your stance because it was a subgroup or not pre-specified, or why did you feel so strongly that it's not the regulatory's decision?
yeah, well, those two things, and also that PDL1 expression's variable, it's inducible, over space and time, and I just don't really think it has the characteristics in this setting uh, of a biomarker that should be used to make binary treatment decisions, which is what you're doing if you're
Yeah.
using it to say these patients can't be treated. I'm not dismissing
Sure.
it out of hand as something
Yeah.
that you might use but I didn't really think that was the role of the regulator, and the FDA have taken the same view, and the MHRA in the UK have taken the same view as well. This is a complicated thing, and I don't think it should have been there. But there we are. I guess that you probably agree, and that's our opinion.
Yeah.
So a couple of other things, I suppose, about Nivo-Rela. One of them would be where we are with OS. Another one would be brain mets. How much data do we have? And then the third thing, what about OS?
Yeah, and talks too, we should talk about. So, the primary endpoint of RELA 047 being PFS means it really doesn't even matter so much what happens with OS. It won't affect an approval. So the drugs got approved, by these agencies, but then in subsequent follow-up, the OS was produced and it did not meet statistical significance. So I think if you're a clinician practicing, there's a few things that matter to you when you're treating a melanoma patient. You want to probably be able to alleviate their symptoms. So if they're having symptoms, you want to be able to reduce their burden of symptoms. That roughly translates into an objective response. If you're getting a response, you're minimizing symptoms. So, we want something with a strong response rate. You also want to be able to ideally tell them, we will have your melanoma under control for X amount of time, the longer the better. So, this PFS comes into that, or time to progression as another endpoint that can be used. Being off treatment, I think, is important to patients, so treatment-free intervals. But ultimately, we're giving treatment to metastatic melanoma patients because we hope that they live longer. We hope that they live longer with manageable tumor burden. We hope that they live longer, minimizing their time on treatment. And I think for me, Relativity-047 is hitting a couple of these marks, but it's missing a couple of the others. So it's got this PFS benefit, but it doesn't have this OS benefit. It's got a manageable toxicity rate, but it's got still, maybe 40% grade 3-4 AEs overall, and maybe treatment related down to about 20% grade 3-4. So it's half maybe the toxicity rate of Ipi-Nivo, but I don't get the sense of patients having as long a treatment-free interval. So because Rela-Nivo comes in a fixed dose, it's all or nothing. With 067, it was, most patients discontinued during the induction phase and didn't then just resume monotherapy. But we know in the real world, that's an option, is to get on monotherapy with less side effects. I don't know. For me, Rela 047 still has a lot of things out there. It doesn't have a strong and objective response rate. It's missing overall survival. But yes, it's got a better toxicity profile. So that's my take on it.
Do you think we're going to see a survival benefit? I mean, we don't really have mature follow-up at the moment, right? And are we going to need to have this conversation all over again if we see positive data for survival, do you think?
Well, I mean, you are famous for this with 067, giving us an update every year, it seems. And Rela 047 has followed suit. It seems like every 6 months or a year we get more and more and more, but nothing has changed the needle here. I mean, we still see the goalpost as a PFS benefit, no OS benefit. If for some reason there's an OS benefit in the long run, of course, that changes the tune. But it's hard to see how that's going to happen if you're not having it already with this shortfall. But of course, things can change. You asked about brain mets, and I think that's a really interesting area, particularly because we want to know about efficacy in patients who have brain mets. And I'm also interested in patients who develop brain mets. So we know with 067, you were referencing some supplemental data in one of the publications that describes time to development of brain mets. And it seems to be the longest in the combination arm. I'd love to see that in this 047. I'd love to see if they were able to capture who developed brain mets. And by the way, that speaks to trial development and databases and designing those smart from the beginning so that we can capture these fields. But there's also the Bluebonnet trial, which is being run at MD Anderson, which is Rela-Nivo for brain mets. So it's for asymptomatic, untreated brain mets, 0.5 centimeters or greater, for basically frontline untreated metastatic melanoma that happens to have brain mets. They can get this dual combination. And that Bluebonnet trial should hopefully report out results soon, so we have some idea about efficacy in the brain.
So when we see the data from that trial, we're going to compare it with CheckMate 204, which would talk about in a separate podcast.
Yeah.
And then we'll put them next to each other. And then what will we do you think? Because it may be challenging even for cross-trial comparisons to see if there's a difference there.
Yeah, I think it's going to we're going to end up doing what we do, which is we're going to think about what really matters to our patients. Is it time off treatment? Is it toxicity? Is it, with CheckMate 204, there's only a finite amount of treatment you get there in combination, whereas with obviously with relativity or with Rela-Nivo, you're going to get it probably longer. So we'll have to think about what matters, but we have to be charmed by that name Bluebonnet. That's the state flower of Texas. So that was done not I guess unintentionally to name that study the Bluebonnet study.
Is that right? So in your clinic in Denver, who are you going to be treating with Nivo-Rela? Is it going to be replacing anti-PD-1 monotherapy in, substantial numbers of patients? And we probably need to put to one side the question of people who failed adjuvant treatment previously, because that kind of makes things somewhat complicated. So question is it replacing anti-PD-1 mono substantially or not? And to what extent is it replacing Ipi-Nivo? Because it's somewhere in the middle, isn't it? I'm trying to figure out where in the middle.
Okay, so I am, for anybody listening, I'm probably standing on an island, a very small island of my own. I do not, across the board, replace anybody I was going to give PD-1 monotherapy with this Nivo-Rela combination. For one, there's some real toxicities that are of concern. There's a higher rate of adrenal insufficiency and myocarditis, and those are not inconsequential if they develop. So that toxicity rate, obviously, I'm going to be careful about that. There is messaging that if anybody you're going to give PD-1 monotherapy to, now you give them Rela-Nivo because of the 047 trial. The reason I don't believe in that is some of this subtle stuff where you said the regulatory bodies should not be the ones to determine the binary access or no access to a treatment. This is where I think it does come in. It comes in the exam room. So I will look at a patient. If I think they can tolerate the combination of dual checkpoint inhibitor, then I'm likely to go with CTLA-4 PD-1. I like Ipi-Nivo as my frontline. If I have concerns if they can tolerate it, then I'm really getting into, well, then what are the characteristics of their tumor? Are they a tumor that is expressing PD-L1? If they have PD-L1 expression in that tumor, understanding that it's inducible, it's a static picture, that one tumor is a snapshot in time. But if that one tumor, and ideally it's a tumor that was proximally resected to whenever we're starting treatment or biopsied or whatever, if that tumor is expressing PD-L1 at some real percentage, 5%, 10% or higher, I start with PD-1 monotherapy, because I feel that the monotherapy really can be effective in those situations. But I don't treat them to progression. I will then, after a couple of rounds of it, do a quick scan or a quick peek at their LDH. And if I feel like we're not already seeing a response after 2 or 3 rounds of PD-1 monotherapy, I then escalate it to Nivo-Rela. So I don't treat to progression and then tuck in Nivo-Rela. I sort of do an early assessment. And if I'm not getting the clinical benefit, the response really. And I will say, anecdotally, I ask my team to just kind of watch this. When we have patients who have PD-1 expression, 5, 10%, whatever, and we give them PD-1 monotherapy, the response rate is generous. It's beyond 50%. So I don't have this situation where I'm often having to escalate to combination after trying monotherapy for a PD-L1 expressor, but it happens. And that's when I reserve my Nivo-Rela. That's a really long answer. That's why it sits somewhere in the middle for me. What about you?
So that's really interesting, actually, in several ways. I mean, first of all, the image of you on an island, and then I think you did some peeking, and then you did some tucking, if I'm not mistaken. So It was lovely, lovely picture. Yeah, we don't kind of really have the ability once we've chosen one regime or regimen to then go to another one. So we need to kind of go all in at the start, as you might say. But that's a really interesting idea, and it makes a lot of sense, I have to say. So I haven't really been looking at the time, but we probably just about need to wrap up on this, I think, now.
Yeah, I mean, I was going to tell you one other thing that I sometimes do, just as a side. We could cut this from the episode, but you know what I've started to do is sometimes I give patients Nivo-Ipi if I really do think they need it, and then at that 4-cycle scan, if they're not a complete responder, if they're a partial response. I mean, I still remember that one presentation probably Georgina gave where it was CheckMate 067 by response. I mean, it's our statisticians and SWOG say you can't graph things like that because that's graphing by some event that happened after study start. But complete responders do better than partial, do better than stable disease. Duh, that's science at the obvious. But the question is how many partial responders turn into complete responders? So how many go from this curve to this curve, right? And there's some that do that. And so if you're on 06, if you've gotten your 4 doses and you're a partial responder, you're not yet a complete responder, and I'm a little worried about monotherapy just turning us into a partial responder for life instead of a complete responder, then I actually switch them then to Nivo-Rela. So then they get combination forever. They get 4 doses of combination Nivo-Ipi, and then they get maintained by Nivo-Rela combination. And that's a study you probably just need to design in the UK in order to, if you can't access it that way, just ask BMS to allow you to do some sort of scan that would then say if they're a complete response, I go to Nivo mono, and if they're not, I give them Nivo-Rela or something. And you get combination forever.
Yeah, that's nice. Kind of intensification type of approach, chasing a CR, and exposure to maximum number of agents in those who haven't had a sufficient response. Very interesting.
Yeah. Because I think if Nivo-Ipi can't give you this year, I don't think Nivo-Rela was going to necessarily have given it to you, but I think your maintenance is going to be better than just monotherapy. I don't know. It's just something.
Yeah, it's a nice idea for a study, actually. I guess one thing with these kinds of studies now is that Ipi's coming to the end of its patent life, and so you need to kind of factor that in. As well as, I guess, the sort of potential commercial considerations. So anyway, thank you. That was great. I guess I need to wrap up a little bit on Relativity-047, Nivo-Rela, first-line treatment, metastatic melanoma, superior to Nivo mono. Progression-free survival. Haven't seen an OS benefit yet. Tolerability definitely better than Ipi-Nivo, but more side effects than anti-PD-1 monotherapy. Bit of difference between the regulators around the world about the approval in terms of PD-L1 expression, but some interesting ideas there from you, Sapna. Thank you about how you might do this in clinic. And I guess the thing is, we've still got relatively immature follow-up from this study, and for me, that's kind of the biggest thing. What we're going to see, I hope, in the near future. And then the other kind of question is, how long is this study going to be followed up? There's a label, as you said already. Maybe we're not going to see very long-term follow-up of this study. Watch this space. Thanks very much.
I don't know. I mean, the fruit of the blooming tree. We'll see how much more fruit we get off of this tree. But yeah. Thanks, James.
Thank you.
Hi, everybody. A fact check now for this episode, Relativity-047. Once again, I think we maybe didn't mention the citations here. So relatlimab, nivolumab versus nivolumab in untreated advanced melanoma, the original publication by Hussein Taubi et al., New England Journal of Medicine, 2022. And then the overall survival and objective response was published the following year. The manuscript is called Overall Survival and Response with Nivolumab and Relatlimab in Advanced Melanoma, New England Journal of Medicine Evidence, 2023, first author Georgina Long. There was also a health-related quality of life with nivolumab plus relatlimab versus nivolumab monotherapy in patients with previously untreated, unresectable, or metastatic melanoma Relativity-047 trial. This is Dirk Schottendorf, first author in the European Journal of Cancer, 2023. Early in the episode, we talk about EMA, and I call it the European Medical Agency, but it's more precisely, it's the European Medicines Agency. I guess more accurately, I should say, European Medicines Agency. And then I guess we should also mention the MHRA. So MHRA is the UK regulatory authority. It stands for Medical and Healthcare Products Regulatory Agency. I'm sure it sounds much more posh if James had said that. And then we also have a little debate over the absolute benefit of ipi-nivo over nivo monotherapy. And I said, is it maybe 10%, similar to the benefit of doublet over mono that we see in Relativity-047? And James said, no, go read the early publication. It's closer to 15%. Of course, he's right. It's 13.9%, the absolute benefit. It's a benefit of about 57% with doublet over 43% with nivo monotherapy. And that's it for the fact check for Relativity-047.